We start the next session. A very good morning and welcome you all to the next important session on ocular tuberculosis. I'll give a brief introduction about and an overview about ocular tuberculosis. When you look at the burden of tuberculosis, in 2023, the global burden was around 10.8 million, and the incidence in India was about 2.5 million. That means there were about 25.5 lakh cases reported in 2023. So ocular TB is emerging as an increasingly recognized clinical entity. And we should remember that 92% of patients with ocular TB present without any evidence of concomitant pulmonary tuberculosis. So ocular TB is maybe the first presentation of tuberculosis in an initially asymptomatic patients, and it is a great masquerader or imitator of various ocular pathologies. It is caused mainly by active infection or by an immune-mediated response. Active infection could be due to reactivation of the dormant bacilli or due to hematogenous spread or direct invasion into the local ocular tissues. So what are the challenges that we come across in ocular TB? Because of the heterogeneous clinical manifestations, mixed ocular tissue involvement, and lack of uniform diagnostic criteria and gold standards, and also it is very difficult to get histological or microbiological evidence of infection in many cases. So most cases of ocular tuberculosis are presumptive. So primary ocular TB may affect the eyelid, conjunctiva, cornea, and sclera as different manifestations. We'll be discussing about the phenotypes of ocular TB in another talk. So I just want to highlight this. Two patients who presented with necrotizing scleritis was extensively investigated, and finally, with the evidence of a very strongly positive MANDO, the patients were started on ATT and systemic steroids, which showed very rapid resolution. And secondary ocular TB can affect the uvea, retina, and optic nerve as various manifestations, which will be discussed in later talks. This again, a 25-year-old female, came with defective vision, pain, and redness of the left eye, and fundus shows multifocal choroiditis and choroidal granuloma, and with a strongly positive MANDO, she was put on ATT and steroids and shows very good resolution. Another patient who was diagnosed with miliary tuberculosis, you can see the choroidal granuloma as well as the exudative RD, under which there was an evidence of choroiditis. And she also responded very well to ATT. So we have to consider ocular tuberculosis in the differential diagnosis of all these conditions. That is why it is said that it is a great masquerader. So diagnosis of ocular TB is based mainly on the clinical phenotype, supported by the immunological investigations and radiological investigations. We have the tuberculin skin test as well as IGRA. And managing ocular TB needs a comprehensive approach with a combination of ATT and adjunctive treatments like systemic steroids. And collaborative ocular tuberculosis study also provide consensus guidelines for initiating ATT in various forms of tuberculous uveitis. Monitoring and follow-up of tuberculosis also is patients on ATT is very important, because nowadays we are seeing lots of cases of ATT toxicity. So, in conclusion, we as ophthalmologists have to take the decision to treat ocular TB. And based on supportive ocular findings and corroborative investigations, we have to decide on the treatment. Recognition of phenotype is a very important step. We have various newer imaging modalities, and the COTS group also provide consensus guidelines for initiating ATT. So in our IC, ocular tuberculosis, a closer look into an increasing reality. We have several topics, typical and atypical phenotypes of tuberculosis, diagnostic challenges, and current practice in the management of ocular TB, as well as ocular toxicity with ATT. So for the first talk, I invite Dr. Sitara to present the typical and atypical phenotypes of ocular tuberculosis. Over to you, Dr. Sitara. Thank you.
Thank you, ma'am. Good morning to one and all. Presenting the topic of typical and atypical phenotypes of ocular tuberculosis. Ocular tuberculosis represent a form of extrapulmonary TB which can affect various ocular tissues and can present with a wide range of symptoms. The pathogenesis of ocular tuberculosis. The current understanding of TB uveitis pathogenesis relies on the concept that ocular inflammation can be because of a hematogenous dissemination of Mycobacterium tuberculosis, causing a direct infiltration to monocyte and related granuloma formation. The central role of RPE in Mycobacterium tuberculosis and phagocytosis and orchestrating of immune response have been identified. There is also the presence of autoreactive intraocular T cells and an elevated levels of cytokines like interleukin 6, 10, VEGF factors. Intraocular tuberculosis is a great mimicker of various uveitis entities. TB uveitis is a conundrum because of its diverse clinical phenotypes. Now, how does TB present in the eye? There could be a typical phenotype as well as an atypical phenotype. Typical phenotypes, if you see them, you think of TB. Atypical phenotypes are those which becomes a diagnostic challenge. The phenotype doesn't look like TB, but the TB test becomes positive. So the various clinical presentation of ocular tuberculosis, it can be of an intraocular tuberculosis presentation or as well as an extraocular presentation. The intraocular presentations could be of a anterior uveitis, intermediate uveitis, posterior uveitis, and a panuveitis, retinitis, retinal vasculitis, neuroretinitis, endophthalmitis, and panophthalmitis. Now let's get over them one by one. The typical presentation of anterior uveitis is of a chronic granulomatous anterior uveitis with mutton-fed keratic precipitates and iris nodules, which if present near the pupillary border is called as Koppe nodule, and the stroma it is called as Busacca nodule. There would be also the presence of a broad-based posterior synechiae. Intermediate uveitis usually presents with unilateral or bilateral asymmetry that resembles pars planitis. The features include moderate to mild vitritis, large snowballs, snow banking, peripheral vascular sheathing, cystoid macular edema. So this is a fundus picture showing snowballs in a patient with intermediate uveitis. FFA shows leakage in the typical wheel-spoke pattern suggesting of cystoid macular edema. The second presentation would be of a posterior uveitis, which predominantly involves the choroid inflammation. In tubercular posterior uveitis, the ocular changes can be divided into 4 groups, that is in the form of a choroid tubercles, tuberculoma, subretinal abscesses, and a serpiginous like choroiditis. First, choroidal tubercle, that is a multiple small grayish yellow nodules with indistinct borders which may be unilateral or bilateral, predominantly located in the posterior pole. The margins later become sharp and distinct and the center turns yellow to white with a surrounding ring of peripheral pigmentation, and this process eventually results in the formation of an atrophic scar. This is an FFA picture of the choroidal tubercle which shows early hyperfluorescence of the peritubercular tissues with a hypofluorescence of the tubercle which appears as a ring of fire appearance. Late phase, the fundus fluorescent angiography shows a uniform hyperfluorescence. The tuberculoma would be the second presentation, which can be appearing as a single multiple yellowish subretinal lesion with the fuzzy borders surrounded by exudative fluid. Hemorrhages and retinal folds may be seen in the tuberculoma surfaces. This is a right eye fundus photograph showing a tuberculoma. The OCT shows large homogeneous hyporeflective choroidal granuloma with a subretinal fluid, which can be a contact sign. ICGA shows hypofluorescent lesion in the early phase, remaining hypofluorescent in the late phase. So we often get confused with sarcoid tuberculoma and tubercular uveitis, which can be differentiated with OCT as a large elevated lesion in the choroid involving the outer retina. In sarcoid, there will be stromal involvement with multiple. It's not as big as the choroidal tuberculoma seen in the tuberculoma. It's seen as a very minimal outer retinal changes when compared to the TB retinal granuloma. The second feature, the other feature could be of an occlusive retinal vasculitis, which is typically presented as in the form of a retinal periphlebitis, involvement of the vein rather than arteries. There could be perivascular sheathing with exudates and retinal hemorrhages. The presence of perivascular choroidal pigments or small choroiditis patches is highly suggestive of a tubercular etiology. The complication of occlusive retinal vasculitis could be of a macular edema because since it's an occlusive nature, it could have a retinal and optic disc neovascularization resulting in vitreous hemorrhage, tractional retinal detachment, iris neovascularization, and neovascular glaucoma. Eales disease is an idiopathic form of occlusive retinal periphlebitis with a high risk of retinal neovascularization and related sequelae in young healthy individuals from TB endemic areas has been strongly correlated to an immune-mediated reaction to Mycobacterium tuberculosis. This is a fundus picture showing leakage from the vessel wall with more intense from the venules and adjoining capillary non-perfusion. The other picture would be of a serpiginous-like choroiditis, which can be multifocal and a diffuse plaque-like choroiditis. Multifocal is initially a discrete, later confluent yellowish lesion, slightly raised edges, showing an active edge, a wave-like progression and a central healing. Which can be non-contagious to the optic disc. It is unilateral or bilateral with mild vitritis. The diffuse plaque-like choroiditis shows a solitary placoid lesion with an amoeboid spirit. So this is a fundus photograph which demonstrates extensive retinal pigment epithelial changes, atrophy and bilateral scarring. The FFA shows a hyperfluorescent centrally with a hyperfluorescent borders which do not leak. ICG shows lesions as hypocyanes. How do we differentiate between a serpiginous choroiditis and a serpiginous-like choroiditis? Serpiginous choroiditis is a bilateral condition. Serpiginous-like choroiditis can be a unilateral or a bilateral condition. There is absent vitreous or anterior segment inflammation seen in a serpiginous choroiditis. The other can be associated with an inflammation. The lesions begin juxtapapillary. The lesions are usually beginning in the posterior pole. There is pigment clumping at the borders of the heat lesions and pigment clumping in the center of the heat lesion. This is not a multifocal lesion. This becomes a multifocal. So how does TB affect the optic nerve? It can be in the form of an optic nerve tubercle, papillitis, papilledema, optic neuritis, retrobulbar neuritis, neuroretinitis, optic chiasmic arachidonitis. There can be the presentation of an endophthalmitis or a panophthalmitis. This is of an acute onset and shows rapid progression with destruction of the intraocular tissues. The inflammation may be intense enough to produce hypopyon. These were the typical manifestation. Moving on to the atypical manifestation. Atypical manifestation can be of a wide variety of uveitis, from a non-granulomatous anterior uveitis to an intermediate uveitis, non-occlusive retinal vasculitis. TB should be excluded in all cases of atypical anterior uveitis not responding to conventional therapy in patients with socio-epidemiological risk factors for TB. Not to forget to mention about the extraocular tubercular manifestation, which can affect the eyelid in case of a localized mass, lacrimal gland as granuloma, conjunctival granuloma, ulceration, hypertrophied papillary lesions, sclera as a focal or a non-necrotizing scleritis, nodular and diffuse scleritis, scleromalacia. Cornea can be in the form of an interstitial or a diffuse keratitis, flictinulosis, and corneal edema. Just to mention few case reports published in various journals. So the first case is of an unusual presentation of a tubercular panuveitis, initially diagnosed as misdiagnosed as sympathetic ophthalmitis, and hence was treated with IV and corticosteroids and immunosuppressive. But due to worsening of the symptoms in chorioretinal lesions, the patient was further investigated and was found to have a positive tuberculin test, and CT showed a positive mediastinal lymph nodes. And on enucleated specimen of the left eye showed the presence of acid-fast bacilli. Hence, the patient was started on ATT and the symptoms got cured. This is another case report which shows immunocompetent women presented with a subacute intraocular inflammation with high intraocular pressure, which was mimicking a phacolytic glaucoma. The further treatment was done, cataract extraction was done, and was put on anti-inflammatory medications. Inflammation did not subside as expected. 7 weeks later, the patient presented with the scleral necrosis or scleral abscesses, which was subsequently explored for microbiological investigation and was found to be having a tubercular etiology, for which anti-TB was treated and the abscess was cured. This is another case report which shows a rare presentation of ciliary body and limbal lesion, which is diagnosed in an immunocompetent young female or male. The individuals with compromised immune status usually presents with atypical presentation. Tuberculoma in the sclera is a rare presentation of tuberculosis and with very few reports. This is another unusual case which was of a tubercular optic neuropathy associated with a choroiditis. So a case of presumed tuberculous optic neuropathy with a concurrent choroiditis which presented following a choroidal involvement in the other eye. This case highlights the contagious spread of the infection from the choroid to the optic nerve and its successful management with the systemic steroid and ATT. Choroidal involvement in a case of inflammatory optic neuropathy should raise the suspicion of a tuberculous etiology. These cases emphasize the need to be aware of the ocular tuberculosis in an endemic area, especially with unusual presentation and prolonged clinical course of the ocular inflammation. So finally, to conclude, when to suspect TB? Typical phenotype, the phenotypes itself makes us think of the tubercular etiology. What about a typical phenotype? We need to suspect when all other possible infections or diseases is ruled out. Disease is recurrent despite the treatment with corticosteroid or immunomodulator therapy. In endemic countries, TB must always be ruled out. Sometimes, when repeated, test becomes positive for TB. Thank you.
And thank you, Dr. Sitara, for a very informative talk on the different phenotypes of ocular tuberculosis. Next, I invite Dr. Rajni Nair, Assistant Professor of Ophthalmology, KMCT Medical College, for her talk on the diagnostic challenges and approach to ocular tuberculosis.
Good morning, everyone. So I'll begin with what are our challenges. So to begin with, the gold standard of TBU is the detection of Mycobacterium tuberculosis in ocular tissues or fluids. Demonstration of this bacillus by smear or culture from ocular samples is seldom achieved because of the low tissue load and obviously small size of ocular tissues biopsy samples. And ocular TB can involve any part of the eye and can occur with or without evidence of pulmonary or extrapulmonary TB disease. In this scenario, diagnosis of ocular TB is in most cases presumptive, and therefore we rely heavily on the characteristic features and ancillary investigations. So, namely the TSTs, IGRAs, and chest X-rays, chest imaging. So, a quick refresher on the tuberculin skin test. It is done by intradermal injections of a purified protein derivative, which is a mix of antigens, which may include specific to Mycobacterium tuberculosis and non-specific forms of MTB and BCG. Therefore, there are chances of a false positive, especially in those vaccinated after infancy or twice in their lifetime. The reading again, criteria for positive TST again depends on the immune status of the patient, with lower cutoffs having to be taken for immunocompromised individuals. Second generation tuberculin skin tests have been introduced, come into the market since the year 2022, and these new MTB antigen based tests have using the MTB specific antigens ESAT6 and CFP10. Emerging evidence suggests that these tests may offer similar specificity to IGRA, and when compared with MANTO, they may provide more reliable results in children and in people living with HIV. CYTB is one of these tests. It's developed by the Serum Institute of India, and it uses a 1:1 ratio of two recombinant proteins, the ESAT6 and CPF10. And it is administered by the same intradermal method, but the induration is of greater than 5 millimeter is considered positive regardless of the immune status of the patient. There is also a similar test produced in Russia, Diagnostic test, and here any presence of any induration or papule is considered positive, and it's just graded into poorly expressed, moderately or pronounced response. There is a similar CTST. This is also second generation tuberculin skin test that's produced from China. Now coming to the IGRAs. What are the IGRAs? IGRAs are in vitro method aimed at measuring interferon gamma release to antigens of MTB. These again IGRAs are based on the lymphocyte response to the two specific antigens, and the results are not affected by prior BCG vaccination, making these tests more specific than the traditional tuberculin skin tests. The IGRAs are available as two different tests, the quantiferon and the T-spot test. Quantiferon TB Gold Plus is the newest generation of quantiferon tests, and it is an assay which is done on a whole blood using peptides that simulate ESAT6 and CFP10. This assay has 4 tubes. One tube contains the mitogen and acts as the positive control. Another one contains nothing and it's the negative control. The third tube contains the TB specific antigen. And the fourth tube has the same antigen mix, but the peptide lengths differ to elicit cell-mediated immune response both from the CD4 and CD8. The fourth tube was developed with the aim to improve the detection of latent TB infection among recently exposed contacts, immunocompromised hosts, and young children. Report is then quantified as interferon gamma in international units per millimeter. The cutoff is provided by the manufacturer. T-spot TB assay is an ELISpot assay where again the antigens are incubated with peripheral blood mononuclear cells. The T-spot test requires a additional normalization step, which the peripheral blood mononuclear cells are isolated, washed and counted to ensure reproducibility. The tests are then, the test has 4 wells to which this isolated PBMCs are placed, and one well will contain nil, the other will positive control contains phytohemagglutinin, and 2 of the M. tuberculous specific proteins. So reaction within those 2 wells gives you a positive result. So in short, what is the difference between an IGRA and TST? The advantages are it requires only 1 visit. There is no cross reaction with BCG, and a limited time frame from draw to incubation. TST requires 2 visits, and it also changes because there is a subjective determination of results in TST. However, IGRA is exempt of that. But they both share the same disadvantage that they cannot differentiate between latent and active TB. Chest X-ray is the other modality that we use. There are no radiological features which are themselves diagnosis of primary TB, but the presence of consolidations, hilar enlargement due to lymphadenopathy, typical features of primary TB. In chest imaging, HRCT is preferred to X-rays where possible because of the higher sensitivity in detecting lesions. Now coming to the management, the COTS group is an international expert-led group that came up with the consensus guidelines to guide the initiation of ATT in patients with tubercular uveitis. An endemic country was defined as that which had more 100 cases per 1 lakh person, and again the tests used were TST, the IGRA, and chest X-ray or computed tomography. COTS experts concluded therapeutic decision is making is influenced by the specific phenotypes and the endemicity of the patient. The report 1 dealt with the tubercular serpiginous-like choroiditis, multifocal choroiditis, and tuberculoma. So coming to the tubercular serpiginous-like choroiditis, it is a phenotype which has a strong predictive value for ocular TB. And in an endemic region, an isolated tuberculin skin test of greater than 10 millimeters was sufficient to initiate ATT. Tuberculomas are also another phenotype which is highly representative, and commencing ATT should be considered if 1 immunological test with positive results and no radiological finding, or just a positive chest radiography alone was sufficient to start ATT. Focal or multifocal choroiditis, however, have relatively weak association. The use of ATT must be supported by 1 immunological and radiological sign suggestive of old, healed, or active pulmonary TB for patients from regardless of endemicity. Now, the second report has dealt with tubercular anterior uveitis, intermediate, and pan and retinal vasculitis. So, tubercular anterior uveitis, the clinical phenotype of recurrent anterior granulomatous uveitis, whenever one of the immunological tests, either PPD or IGRA, along with chest X-ray, it is advised to initiate ATT. However, in the first episode of ATT, all 3 tests should be positive to start ATT. In tubercular intermediate and pan uveitis, when all 3 tests are positive, there is a absolute consensus in both endemic and non-endemic areas to start ATT. However, in endemic regions, either one of the tests and along with the positive chest X-ray or CT findings is enough to start tubercular treatment. Retinal vasculitis, 2 scenarios, either active or inactive retinal vasculitis. So PPD, IGRA, and chest X-ray are positive, you have absolute consensus, or if one of the 2 immunological tests are positive with a chest imaging. In an active retinal vasculitis, there was only a weak consensus to start ATT despite positive immunological and radiological findings. So what are the summary? In general, all patients suspected of ocular TB should be managed jointly by the ophthalmic specialists and the TB centers. So in the ophthalmic clinic, when a patient with uveitis comes with a positive IGRA, the tests that has to be done include urea and electrolytes, a liver function test, full body counts, chest X-ray, and syphilis serology, also screening for HIV, hepatitis B and C, and sputum samples. If there is a history of coughing, sputum samples for acid-fast bacillite and gene expert has to be sent. Then tests should be according to the ocular phenotypes or systematic inquiry and clinical findings elsewhere. Should include HLA, serum ACA, C-reactive proteins, ANCA and ANA, toxoplasmoserology, all depending on the phenotype that we have and other clinical findings. Imaging should ideally have color fundus images are recommended for documentation and monitoring, preferably wide field with autofluorescence images where available. Macular OCT, standard practice for evaluating macular lesions and macular edema. Wide field angiography is recommended where retinal vasculitis is suspected or to further characterize the chorioretinitis. The respiratory TB clinic should be have an urgent chest X-ray and consider CT thorax with contrast to guide sampling to sample induced sputum bronchoscopy or endobronchial ultrasounds in patients with suspected OTB. So to conclude, the TST and IGRAs are useful immunological tools in identifying individuals with prior TB infection and are an additional and useful tool in a composite approach to diagnosing presumed OTB. IGRAs may be associated with false negative and active TB and should not be used as a sole tool to rule out OTB. A combination of both IGRAs and skin tests may offer the best sensitivity. And the COTSCON calculator, the online calculator that is available, I think will be discussed next in the management. Thank you.
Thank you, madam. That was a very enlightening speech on the diagnostic challenges and approach. Now we'll see the current practice in the management of ocular tuberculosis. We have Dr. Sandhya Somasundaram, Professor, Calicut from Calicut Medical College. Over to you, madam.
Okay, good morning. Actually, my job has been simplified by Dr. HD. Most of the slides will be overlapping, but it will just be a revision for you. So, as per Sun classification, the typical phenotypes as described earlier are anterior uveitis, intermediate uveitis, pan-uveitis, and posteriorly retinal vasculitis, choroidal tuberculomas, serpiginous-like choroiditis, multifocal or unifocal choroiditis. Now, as Dr. Rajani has previously described, we have a collaborative ocular tuberculosis study. And in that anterior uveitis, to be considered as tuberculosis, it should be typically granulomatous with mutton fat capies and nodules. It should be bilateral and recurrent, associated with iris granuloma and associated vitritis, extensive posterior synechiae, and seclusio pupillae. And also chronic non-granulomatous anterior uveitis also may be considered in this. So if you feel that the anterior uveitis has all these features, in an endemic country like India, you can consider starting ATT when one of the immunological tests is positive along with a positive radiological test. That is, either your MANTO or PPD is positive along with HRCT or chest X-ray. Regarding intermediate uveitis, actually the consensus was lower in the COT study group when compared to pan-uveitis. So they say in an endemic country like India, there was only moderate consensus to start ATT. Again, just like in anterior uveitis, when one immunological test is positive, along with one radiological test. Then again in pan-uveitis, similar. But in pan-uveitis, both in endemic and non-endemic areas, there was moderate consensus to start ATT when one immunological test is positive along with one radiological test. Then, as Dr. Rajani said, in active retinal vasculitis only we do consider it as tuberculosis. Active retinal vasculitis means you have features of vasculitis along with vessel involvement along with evidence of ocular inflammation. If there is no evidence of ocular inflammation, you consider it as inactive retinal vasculitis. So in active retinal vasculitis in endemic areas, absolute to moderate consensus was there to start ATT when one immunological test is positive along with one positive radiological test. So the conditions which we have described as of till now, that is anterior uveitis, intermediate uveitis, pan-uveitis, and for active retinal vasculitis, all these conditions in an endemic area like India, you can start ATT when one radiological test is positive along with one immunological test. In tuberculous choroiditis, the features are actually it can present as choroidal granuloma or tuberculoma. Or it can occur as serpiginous or serpiginous-like chorioretinopathy and unifocal or multifocal choroiditis. First is choroidal tubercles or tuberculoma. This is the most common and best clinically documented manifestation of ocular tuberculosis. So, since this is a highly suggestive phenotype of ocular tuberculosis, you can start ATT in an endemic country if only one immunological test is positive. That is, you need not have a radiological evidence to start ATT. Then again in serpiginous-like choroiditis, it is highly suggestive of tuberculosis. So again, in endemic countries, you can start ATT when only one immunological test is positive. But in focal or multifocal choroiditis, it can be tuberculosis, but you're not sure whether it is tuberculosis clearly. So since it has got weaker association, you need the support of one more radiological test. That is, immunological test plus one radiological test should be positive to start ATT. So among the conditions described till now, choroidal tuberculomas and serpiginous-like choroidopathy, we can start ATT based on positive immunological test alone. So this is the newer COTS calculator which is developed. You can scan the QR code and see. That will take you to the COTS calculator page. So actually it is for general ophthalmologists to guide, to initiate starting ATT. So if you scan and see, you will go to the page of COTS calculator. Actually, it shows a page like this. You can enter the patient details in that. And you have a clinical phenotype in this. That is, in this clinical phenotype, there are many drop downs. That is, you can diagnose it as, you can mark it as anterior uveitis, retinal vasculitis. You have multiple options in that. And when you fill, finally, you will get a tab like this, calculate. And after that, you will get a score, which ranges from 1 to 5. And IQR, interquartile range, which ranges from 0 to 3. So if the score is actually a score of 5 means very high probability to start ATT. And score of 4 means higher probability to start ATT is there. And IQR 0 means more than 90% of the experts that agree that you can start ATT. So that is an absolute consensus. Whereas IQR 1 is moderate consensus. So a result of 5 with an IQR of 0, 1, 2, and 3 is considered to have reached consensus to initiate ATT in that particular scenario. So in the COTS calculator, if you get a score of 5 with any IQR, you are safe to start ATT. Whereas if it is a score of 4, then it should be, the IQR should be either 0 or 1 to start ATT. Whereas a result of score 1 or 2 or 3 indicates a lower level of confidence for initiating ATT, but it doesn't say that ATT need not be initiated. There are a few clinical scenarios. A 34-year-old female came with complaints of defective vision for 2 weeks. She was having arthritis, which was diagnosed 16 years back, and had taken oral steroids for a short period of time at that time. That is almost 16 years back. She has bilateral renal artery and coronary artery stenosis. Anterior segment was normal. Visual acuity was decreased because of early posterior subcapsular opacity. Fundus showed a few orangish lesions suggestive of choroidal tuberculomas. So Manto was positive. So choroidal tuberculoma, according to the COTS guideline, you can start ATT when one immunological test is positive. But as again said in the previous talk, that is the previous session, this tuberculomas in the choroid can be due to sarcoidosis also. So in that situation, we have to, it is better always, but if the clinical is so suspicious of tuberculosis, then you can start. Here actually Manto was positive, IGRA was positive, but still we took an HRCT which showed multiple mediastinal lymph nodes, and the PET scan was also taken which showed multiple active paratracheal, para-aortic, paracaval, multiple lymph nodes was there. But transbronchial ultrasound and FNAC was negative for CPNAT. And you can see the choroidal granuloma here and small choroidal granulomas in the other eye also. Patient was diagnosed to have disseminated tuberculosis and was started on ATT. The granuloma responded well to the treatment. Another 44-year-old female came with sudden onset of painless loss of vision associated with mild headache. She was diabetic and hypertensive. And on right eye, visual acuity was perception of light with grade 3 RAPD. There was no evidence of anterior uveitis. And fundus shows hazy view due to vitreous floaters. You can see an optic disc granuloma with few multiple choroidal lesions, multifocal choroidal lesions also. And the other eye also showed multiple choroidal lesions. So that is actually multifocal choroiditis with optic nerve head granuloma. Again, in our COTS study, actually it showed that multifocal choroiditis has got a weaker consensus. So it is always better to take an immunological test along with a radiological test. As we said earlier, optic nerve head granuloma can be suggestive of sarcoidosis also. Here also Manto was positive. HRCT showed central lobular nodules in adjacent lung parenchyma, which could be possibly due to tuberculosis. IGRA was positive. So in multifocal choroiditis, along with Manto, the radiological test is also positive. So we started on ATT and steroids. Patient responded well. Now another patient, again 60-year-old male patient with complaints of defective vision, left eye, history of tuberculosis in elder brother, anterior segment normal, posterior segment, yes, it is serpiginous-like choroidopathy in both eyes. And FFA was done. FAF again shows activity. Most of them are atrophic lesions, but some signs of activity was there. And diagnosed as serpiginous-like choroidopathy. Again, ESR was high, Manto positive. Serpiginous-like, it is highly suggestive of tuberculosis. So you need to have only one test. So again here in this, Manto was positive. All the others were negative. IGRA negative, sputum AFP negative, chest X-ray, and CECT thorax also was negative. So since this was highly suggestive, we could start ATT with the basis of positivity of Manto alone. Now take-home messages. In anterior uveitis, intermediate uveitis, pan uveitis, active retinal vasculitis, and focal or multifocal choroiditis, it is ideal to start ATT when one positive immunological test is there along with one positive radiological test. Whereas in choroidal tuberculoma or serpiginous-like choroiditis, which is highly suggestive of tuberculosis, you can start ATT with one positive immunological test. And you can utilize the COTS calculator also for your guidance to start ATT. Thank you.
Thank you, Dr. Sandhya, for that excellent talk. Because the management of tuberculosis is always very confusing. Whether to start treatment or when to start treatment, you have given more clarity with your talk. Thank you. Now we move on to the last talk of the session, ocular toxicity with ATT. Are we missing the timely detection? By Dr. Aishwarya S., Assistant Professor, KMCT Medical College.
So very good morning to all. As for the physicians, for us ophthalmologists also, the ATT toxicity is always a topic of problem. So especially ethambutol, which remains a double-edged sword. So my question is, ocular toxicity with ATT, are we missing the timely detection? So just an introduction, the ATT regimen, the first 4 line drugs are isoniazid, rifampicin, pyrazinamide, and ethambutol. Ethambutol is our culprit and it was invented in 1961. It acts by inhibiting arabinosyl transferase and thereby inhibiting the cell wall synthesis. So it is one of the safe and one of the systemically least toxic drugs. So the pulmonologist is relatively happy with this drug, but because of its chelating properties, we are not. So it's one of the drugs, within 2 years of invention, we could see optic neuropathy. And till from 1963 to 2024, there is no much treatment for the reverses of optic neuropathy. So the emphasis is always on early detection and stoppage. So why there is a sudden uproar about ethambutol toxicity? For that, you should know the evolution of TB elimination program in India. So RNTCP, according to the National Tuberculosis Program that was initiated in 1962, and in 1997, we had the DOT strategy. That is the directly observed treatment short course. According to that, the 4-line drugs were given in the presence of a supervisor. That was also fine. But in 2016, a daily weight band wise fixed drug regimen was based on the drug sensitive TB regimen was introduced. So that was the new guidelines. So what happened in the new guidelines? What is the comparison of the new and old guidelines showed that from the previous guideline, there was a thrice a week regimen. It was changed into a daily regimen, daily intake of the drug. And what was the change? Initially, there were 4-line drugs that was given singly. It was a single strip containing all the 4 drugs and that was taken together. But in the new, it is a single drug. That is a single tablet which contains all the 4 drugs together. That's a single tablet and that is taken. So according to that, there is a fixed dose combination as far as the weight band was introduced. And also, it was given in the continuation phase also. Ethambutol was continued in the continuation phase also. The total duration became from 2 months to 6 months. So this was that fixed drug regimen. According to that, you can see in the adult, it is a single tablet containing all 4 drugs. But in the pediatric, again, the 3 drugs are combined to a single tablet, but the ethambutol is given singly. So in this, you can understand the total duration increased from 2 months to 6 months and also the total. And it was given according to the weight band. For example, for a 25 kg person, it's 2 tablets. And for a 70 kg and above, it is 5 tablets. So the total duration and also the total drug intake in this increased. So that is again a point of concern. So this was very happy for the pulmonologist because there was an increased patient acceptance due to fewer drugs to solo, increased health worker compliance because fewer tablets to handle, easy drug management, low risk of misuse of single drugs, and a low risk of drug resistance, which is a major problem in the case of TB. But what happened is, it took away the flexibility of modifying or eliminating the dosage of a single drug like ethambutol. So according to this, in the thrice-a-week regimen, the optic neuropathy was ranging from 0.3 to 12.6%, but in the daily regimen, according to the dose, it changed. For 15 mg per kg per day, it was 1 to 2.5%, but with 35 mg per kg per day, it increased up to 18%. So is ethambutol the only culprit in this? No, something about isoniazid toxicity also. So isoniazid is less common. Around 11 cases of isoniazid-induced optic neuropathy has been reported in the literature so far. It is mainly due to the pyridoxal phosphate metabolism and it is dose dependent. That is about 2 to 108 grams causes optic neuropathies. The fixed drug regimen contains 75 mg of isoniazid, so it comes under this criteria. And it starts as early as from 10 days of commencement, but usually after 2 to 3 months of treatment. But what makes it different from ethambutol is this. That is the reversibility within 4 days of the stoppage of drug, and usually a complete recovery within 4 weeks is expected. So it makes it a lesser problem. So now we'll go into the clinical presentation of ethambutol toxicity, the treatment options that are available, and the protocol for screening and follow-up, and finally, what is the need for reporting an ethambutol toxicity as an adverse drug reaction. So clinical presentation is usually within 3 to 5 months of use. It is usually a subacute, bilateral, painless symmetric loss of vision. It can be also an asymmetric and a sequential one. If it is asymmetric one, pupils are usually normal in the initial stages. Then in an asymmetric case, it can be an RAPD, or the symmetric, it can be bilateral sluggish pupillary reactions. And in the fundus, it can be initially normal, or it can present as a hyperemic disc, a few peripapillary hemorrhages or splinter hemorrhages, and finally in advanced case, that can be an optic disc pallor. So in the functional assessment, there'll be color vision loss, there is reduced contrast sensitivity, on field there is a central or centrocecal scotoma, RNFL there is initial thickening followed by thinning, and the thinning of the ganglion cell layer. On VP, there is a delayed latency and reduced amplitude of the P100 wave. So is there any method to detect an ethambutol optic neuropathy before it has become a fully blown clinical picture? Yes, there is. We can see a ganglion cell loss, or if there is a prolonged VEP or a multifocal ERG, in RNFL initial thickening followed by thinning, or in visual field there is an initial reduction in the visual field index followed by a central or centrocecal scotomas. So when there is a color vision loss, contrast sensitivity loss, or a visual acuity loss, then there is a full-blown picture of ethambutol-induced optic neuropathy. So we had conducted a study in 2021-22. It was a prospective cohort study on ethambutol patients who are on ATT. We examined them on as a baseline, then for 1 month and at 6 months. So according to our study, the incidence was about 34.1%. A high incidence was seen at the end of 3 months of commencement of treatment, and a significant loss of superior temporal and mean RNFL thickness. So definitely ethambutol induced optic neuropathy was increasing. So now the question is whom, how, and when to screen and how to follow them. We would recommend a baseline ophthalmic examination for at the start of the treatment for all patients, but definitely there are some high-risk candidates who should be closely followed up and screened before. So that includes malnourishment, renal disease, diabetes mellitus, tobacco or alcohol abuse, preverbal children, prolonged ethambutol therapy, and also when there is a combined therapy with linezolid, more than 15 mg per kg, or a total duration more than 28 days, and also in a low weight patient. So the protocol for screening and follow-up is usually starting with visual acuity, color vision, contrast, and visual field. These are done in all centers, and in a higher center, you can go with an OCT RNFL and a VEP also. And a 2 monthly follow-up is required, and pediatric group and the high-risk candidate should be given a more close follow-up. One point is the consulting pulmonologist should also be encouraged to ask for drop-in vision and color desaturation. We would recommend to have a visual acuity chart in their OPD also for a basic screening. And the patient is also given awareness about this. And smartphone-based app should be given to them to educate to look for their own visual acuity, and on an Amsler grid to look for their central vision. So now coming to, what are the treatment options available? So there are no effective treatments to reverse the ethambutol toxicity. Stop the drug as early as possible is the dictum. So we can also give them a cocktail of vitamins including hydroxycobalamines, methylcobalamines, thiamine, and pyridoxine. And patient may also be started on ubiquitin, vitamin C, zinc, and copper because they have chelating properties on the micro elements. And if there is no improvement within 4 to 6 weeks, again discuss with the pulmonologist and considers the stoppage of isoniazid, which may be potentiating the toxicity. What is the importance of reporting ethambutol toxicity? It is the responsibility of both pulmonologist and ophthalmologist to report ethambutol toxicity. There is a pharmacovigilance program of India launched by the Ministry of Health and Family Welfare in 2010, and the Pharmacopoeia Commission comes under this, which will address the adverse drug reactions. They collect from recognized teaching hospitals, corporate hospitals, and TB centers. Only if you report the adverse drug reactions and take it into a national level, then you can make a remedial measure at the policy making level. So to summarize the clinical presentations, there is a decrease in vision or a quality of vision. Ocular examination include visual acuity, pupil for RAPD or sluggish reaction, fundus for a hyperemic disc or an optic disc pallor, color vision contrast will be impaired, supportive in visual field there may be centrocecal scotoma, optic disc, then RNFL thickening followed by thinning, and a prolonged VEP. The more importance is on creating an awareness to the physician and patients. A 2 monthly visit should be given, and there will be self-assessment to be educated for the patient also. Treatment, the stoppage of the drug is the dictum. If no improvement, consider stoppage of isoniazid and linezolid. So in the absence of a definitive treatment, it is emphasis always on primary prevention. So report ethambutol toxicity as an adverse drug reaction when you see one, to bring a change at the policy making level. Thank you.
Thank you, Aishwarya, for that wonderful talk. Actually, it is so important, ocular toxicity of ATT, so that we are actually in a position where we don't know how the patient will respond to this ATT, whether they'll develop this ethambutol toxicity. And most importantly, as she said, we have to educate the patient that this can occur, and home-based vision assessment can be done so that it can be detected early. And thank you, Aishwarya, for that.
With this, we have come to the end of this session. I think we have started before time and finished much before time. So there are enough time to ask questions. If you have any questions, we are all here to answer.
No, color vision is not effective in all the cases. Most of the cases, it's not effective. Some studies have shown an color vision defectiveness in about 19% of the cases, but in some case studies, it was normal. No, not even a single patient showed. So that is cannot be a only parameter for diagnosis. So if it's not there, also if you see another parameters, then you have to stop the drug, because if you want to stop it, it is partially reversible. So it not come back to that original vision is very difficult. So you have to stop the drug for anything you find. Yes, ma'am. The dosage is also important because in a 25 kg patient, you are giving only 2 tablets, but that comes to around that 15 mg per kg. But in a more than 70 kg patient, you are giving about 5 tablets, and that comes to about that 35 mg category. So 35 mg category, they are having more concentration. 6 months, they are getting that treatment. So that increased to up to 18% chance of developing. But in the otherwise, it is only about 2 to 3%. So that varies. Studies also that is showing some difference. That is also, it's partially reversible.
Actually, we had talked with pulmonologists, that is after 2 months, whether we can stop ethambutol, but they are not for it because ethambutol is more effective. But in ocular tuberculosis, we can tell to avoid ethambutol. That is, I think, better preferred now.
We have started seeing a large amount of ethambutol toxicity after they have increased the dosage as well as the duration. So it has an effect because when it was for 2 months, the toxicity was not that much seen. Any more questions? If you have no more questions, we'll wind up this session. Thank you all for your participation as well as listening and active participation.